Good morning. Welcome back to Open Med School. Today I am going to discuss IM 1.2, part of Internal Medicine's CBME curriculum. And what I am going to plan is to describe and discuss genetic basis of some forms of heart failure. So we know heart failure is a syndrome. Various etiologies are there. The end result is the heart fails as a pump. So this failure can be either in the pumping, that is, the heart is unable to pump, that is systolic dysfunction, or the heart is unable to accommodate blood, that is diastolic dysfunction. So basically understand that the heart failure can be, that is a pump failure is occurring, the end result, it can be a systolic dysfunction or a diastolic dysfunction. Systolic dysfunction occurs usually in cases of patients with a dilated heart, because heart is unable to pump, so blood is accumulating and so the heart is dilating. And the diastolic failure typically occurs in a hypertrophied muscle, that is a hypertrophied muscle fails to dilate. That is these are the things, basics you should remember regarding the heart failure. So there are a lot of risk factors for heart failure. So we know hypertension, diabetes, dyslipidemia, sedentary life, smoking, all these are risk factors for heart disease. And what is the why it is called risk factor? This all these leads on to ischemic heart disease, that is the coronary artery is dysfunctional. There is another group of disease where the coronary arteries are normal. They are primary disorders of myocardium. They are called the cardiomyopathies. Most of the cardiomyopathies have got a genetic basis, and many of them run in families. So familial and genetic inheritance is there. But again, remember the heart disease is multifactorial. The same patient can have other risk factors. And as we know, many of the risk factors are also inherited. So in a broader sense, genetic base of heart disease includes all these things. So remember this concept of multifactorial causes for heart failure. The common cause of heart failure that we come across are, one is the most important is coronary heart disease, hypertension, and we have already mentioned the genetics, that is familial cardiomyopathies, rheumatic heart disease, then so many other less common things are there. This will be discussed much later. So we should understand the heart failure has got multiple causes. And heart failure, whatever be the cause, the presentation is almost same. We divide mainly into the symptoms of left heart failure and right heart failure. When the left side of the heart is failing, there is congestion occurring in the lungs. So you develop symptoms of breathlessness. So breathlessness is dominant symptom that you get in left heart failure. Whereas in right heart failure, you get the cardinal three symptoms and signs: elevated JVP, tender hepatomegaly, and pedal edema. So these are three cardinal findings of right heart failure. But some patients can have features of both. Starting with left heart failure, they can go into right heart failure or vice versa. This should also be kept in mind. I have mentioned about the systolic dysfunction, diastolic function. So here the diastolic function, the heart cannot pump, so the heart dilates. So thin chambers are there, and the systolic dysfunction can easily be identified by the ejection fraction, which should be more than 50% normally. And when it is less than 40%, we call it as heart failure with reduced ejection fraction. Whereas in the diastolic dysfunction, what is happening, the heart cannot fill, they cannot expand, so the heart fails to dilate. So there is a restriction in the dilation. Typically it occurs when there is a hypertrophy of the ventricles. So somebody with hypertension can have hypertrophy, athletes can have, so, and there is a genetic condition, hypertrophic cardiomyopathy. So these are the few introductory things regarding heart failure. As I already mentioned, the heart failure has got some are genetic, some are acquired, and there is a interplay between the multiple factors for development of heart failure. So coming to the genes, there are a lot of genes which are concerned with the structural proteins, the mitochondria, and the myosin. So many genes are there. So most of the abnormalities are the TTN, genes coding for TTN and LMNA. So it is impossible to remember all these things. So understand that the many heart diseases have got a genetic basis. So that is why it is found that patients with the heart failure, in the families, if you screen, you may be able to identify certain genetic abnormalities. That is important. So you can predict development of heart failure in families. So now we go on to the primary myocardial disease. Just like a muscle disease which produces myopathy, when the cardiac muscle is having an abnormality, it is called cardiomyopathy. We divide the cardiomyopathy. Last time we have discussed the dilated one, the hypertrophied one, and there is a restrictive one. These are three one, and another important one is the arrhythmogenic right ventricular cardiomyopathy. So these are the basic. So in familial dilated cardiomyopathy, the chambers are enlarged. I have shown the picture. The chambers are enlarged. There are genetic mutations in the genes encoding sarcomeric, cytoskeletal, nuclear envelope proteins. Various mutations are there. I already shown the TTN encoding titin, LMNA encoding lamin, and MYH7 coding for the myosin heavy chain. These are the important. It is not easy to remember all these, but remember that there is a genetic component for most of the cardiomyopathies. Then the strong association, autosomal dominant inheritance for the hypertrophic cardiomyopathy. Again, we have discussed about the thickened myocardia, especially left ventricle, the septal hypertrophy. The patient can develop a sudden death. Then comes so here you can see the asymmetrical hypertrophy. The left ventricle is thickened, especially the septum is thickened. They can obstruct the outflow tract. Patient may develop symptoms similar to that of aortic stenosis. So here this is aortic wall, the blood is easily flowing here. Here there is a obstruction when there is and the chambers are pressed. Small, and this ventricle cannot expand. That is why it produces this is called a diastolic dysfunction. If we check the ejection fraction can be normal. Then there is a familial genetic cardiomyopathy, there is a restrictive cardiomyopathy. Here there is a fibrosis occurring, and when there will be limitation in the expansion. So here you can see this is the picture of a restrictive cardiomyopathy. There is a fibrosis of the chambers producing defective expansion. That is against a diastolic dysfunction will be occurring. Then we have said about the arrhythmogenic right ventricular cardiomyopathy. So the only feature that you will come across will be the ECG. You can get abnormalities. There is a progressive replacement of the right ventricular myocardium with fibrous fatty tissue. Such individuals are prone for development of arrhythmias and death. Again, this is due to mutations. And here you can see the typical ECG pattern, the V1 lead, you will get a change, the inverted T waves. So this is the characteristic finding that you get in arrhythmogenic right ventricular cardiomyopathy. So the interaction with the environmental factors and genetic factors is crucial in the development of heart failure. So today we have discussed about some of the primary cardiomyopathies which are inherited. They are the hypertrophic cardiomyopathy, dilated cardiomyopathy, arrhythmogenic right ventricular hypertrophy. They have got a strong genetic predisposition. In the genes coding for sarcomeric, mitochondrial, and other various structural proteins. So in summary, there are significant factors contribute to various forms of heart failure: the dilated, hypertrophic, and restrictive and arrhythmogenic right ventricular cardiomyopathy. Specific genetic mutations associated with these conditions can help in diagnosis, especially risk stratification and personalized management strategies for individuals affected in the families.